Hello everyone. Myself, Dr. Anju Rani, MD Internal Medicine. I've been working in various hospitals, but at present I'm running my own Anju Rani Arogyam Hospital. I'm here to say something about latest update in hypertension. So here we should go. As per WHO, nearly 63% of total death in India are due to non-communicable disease, of which 27% are attributed to cardiovascular disease, which affects 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factors for CVDs. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow ups. In India, the prevalence has gone up over 31 years to 38% in men and 32% in women from 29% and 28% respectively. WHO, despite that, nearly half of the people or 51% of the men and 41% of women with hypertension were unaware of the condition. Additionally, over 62% of the men and more than 53% of women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released a isolated systolic hypertension 2020 global hypertension practice guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource poor settings. Optimal care refers to evidence-based standard of cares, and whereas essential standards refer to minimum standards of care of allow specification of essential standards of care for low resource settings. The AHA and ACC has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low acute cardiovascular disease risk. Among low risk adults, no CVD for 10 years or CVD risk less than 10%, blood pressure 130 to 90 mm of mercury. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 month duration, then considering a pharmacological therapy, this according to the Jens DW Hypertension 2021. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study, which appears in the Journal of American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to 110 or less than 130 mm of mercury range substantially reduced CV adverse event in the STEP randomized trial, affirming the sprint finding for an older Chinese population among 8,500 patients aged from 60 to 80 years in China. The intensive target trimmed 26% of the complete CV risk. Finding from now a second major trial supporting a lower target could unite the guidelines, which even among US professionals, societies range from threshold of 130 to 150 mm of mercury. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should only be dependent on office blood pressure measurements, but also on out of office measurements, such as ABPM or home blood pressure monitoring. 24 hours and nighttime blood pressure measurements were associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurement for eliminating CV risk. For every 20 to 10 mm of mercury increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension they require lifelong therapy. to achieve optimal blood pressure control. The 2018 European guidelines equally recommend five classes of antihypertensive drugs, considering high non adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and good blood pressure control. Therefore, the 2018 European guidelines recommend, especially in the context of lower blood pressure targets, to start antihypertensive therapy with an initial dual fixed dose combination of AC inhibitors plus or ARB or plus calcium channel blockers or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. The reason, the detection of a known carcinogenic, namely N-nitrosomodimethylamine and NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Zhejiang manufacturing site where the highest level of contaminants were found, every day for 6 years in the highest doses, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by significant increase in the rate of emergency department visit of plus 6%. The Hygia study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The Hygia chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exert a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 175 participants experienced the primary CV outcome. An ambulatory blood pressure measurements were performed for 48 hours to collect data on how PP differed during sleep. The RR reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. Here I am and my talk. Thank you so much.